Thank you. Good afternoon and welcome to this meeting of the Perth Kinross Integration Joint Board of today, Wednesday, the 20th of March 2024. We have a number of important items on the agenda today, so plan to allow plenty of time for questions and discussions, but if we can keep questions and responses concise and succinct, which is a great word that Zoe helped me out with the other day, that would be fantastic. Can we have any apologies or substitutions, please, Clark?
Thank you, Chair. Good afternoon, everyone. We have apologies today from Mr. Bob Benson and also from Ms. Bernie Campbell. I'm not aware of any other apologies unless there are any on the floor. No, that's it.
Okay, thank you very much. Can I ask if there are any declarations of interest in items on the agenda today?
Chair, a non-financial interest in the older people's psychiatric services.
Thank you, Serene. Item 3 on the agenda is the minute of the previous meeting. Can we agree the minute of the meeting of 14th of February? Thank you. Item 4 on the agenda is the action point update. Chief Officer.
Thank you very much, Chair. There is a status update against each of the 4 actions on our action log, with some dates still to be confirmed for a number of those, but just to give assurance that those are in progress. The timescale for 149, which is a Tayside-wide development session by the end of April, is likely to be into May after correspondence with the NHS Board Secretary, but we'll confirm the dates in due course. Thank you.
Okay, thank you very much. Are there any matters arising from either the minute or the action point update? No. Great. So item 6 on the agenda, membership update. Clark to the board, please.
Thanks, Chair. Just to give an update in relation to the NHS Tayside voting members, which have been advised that there's been a decision of the board to update this from the 1st of April. Heather Dunk will be replacing Jackie Jensen as a new non-executive member on the IGB. Bob Benson will also be leaving the IGB, and a replacement appointment to that vacancy will be advised in due course. We also have Sam Riddle replacing Andrew Thompson as the proxy member on the IGB from NHS Tayside. Following these changes, it's been agreed by NHS Tayside Board that Beth Hamilton will now be the Vice Chair of the Perth and Kinross IGB. Lastly, NHS Tayside have advised that Dr. Monica Doyle will be replacing Dr. Lee Robertson on the board from 1st of April as well. Thanks.
Thank you very much, Clark. And can I just say thank you very much to Jackie, Dr. Jensen, as for her time as Vice Chair and the support that she's provided to me as Chair of the board, and can also formally record the board's thanks to Bob Benson for his time as Chair and Vice Chair of the board. Thank you very much. Thank you. Item 7 on the agenda is the item on our strategic objectives. And first of all, can I invite the Chief Officer to give her strategic update and the strategic update on Tayside Mental Health Services. Chief Officer.
Thank you very much, Chair, and thanks for allowing me to run the 2 agenda items together. In terms of an introduction, I would just like to say that I'm conscious that we've got a pretty full agenda today of very important papers. but I would like to recognise publicly the level of work that lies behind all of those papers. Firstly, you have the draft strategic commissioning plan and a presentation on that, which is forward-looking and ambitious and has the voices of our communities and service users at its heart. And our vision, values, priorities and how the IJB will measure and understand how it's making a difference are all articulated in there. We have an update report and a presentation with further engagement before that comes back to the IJB at its June meeting. We also have year 2 of a 3-year strategic delivery plan for people with autism and learning disability, and that provides, I think, substantial evidence of positive change and impact in helping people with learning disabilities and autism to live independently as possible and achieve a high quality of life. It also sets out the next steps in the face of increasing demand and complexity. And the budget paper proposes a balanced budget for the IJB. And just a note that has been prepared and underpinned by significant collaborative work and engagement, and in the context of extreme financial challenges. So I'd like to thank publicly all of the authors of the reports and the teams that have contributed to that for the significant work that lies behind all of these papers. In terms of mental health, we don't have a formal report today because we agreed to receive the next update in June, but I would like to draw the IJB's attention to some matters that have arisen since the last IJB meeting on the 14th of February. So the inpatient mental health and learning disabilities in-year overspend has been met in full for 23-24 with an agreed financial risk share and apportionment across NHS Tayside, Perth and Kinross, Dundee and Angus IJBs. And following on from this, the 3 chief officers and the new Deputy Chief Executive Officer for NHS Tayside, Sandra MacLeod, that some of you will already have met, we have together commissioned a piece of work to agree a shared financial recovery plan with a clear route for agreeing that and monitoring that and delivery in line with the whole system change programme. So a timeline of activity was shared with the programme board on the 13th of March to outline the work that we're going to do there. We have further refined the work streams associated with the whole system change programme, and Sandra MacLeod has agreed to chair the model of care steering group, which brings a number of those together, and the first meeting of that new steering group will meet before the end of March, and there will be service users and stakeholders involved in that meeting. By the end of June, we hope to have a financial framework and a draft model of care to share with all of the IJBs and the beginnings of a commissioning model based on population needs, so an indication of the progress that we're making there. And as is in the action plan. Hello. There'll be a further joint development session in advance of the next IJB, so thank you, Chair.
Thank you, Chief Officer. Do we have any questions for the Chief Officer on her strategic update? No. Cracking through the agenda today. Item 7.3 on the agenda then is the Perth and Kinross Integration Joint Board Strategic Plan for 2024 to 2027. We had a useful development session with members of the IJB on Friday where we got a presentation about the strategic commissioning plan, but I'd like to invite the Head of Adult Social Work and Social Care Commissioning, Zoe Robertson, to introduce the report, please.
Okay. So there should be a presentation coming on the screen that I'll talk through. Yep. Okay, so the presentation you're about to see is relatively short, but gives a high-level overview of the content of the strategic plan. A full first draft copy will be sent out to the membership after the outputs from the 2 development sessions that took place last week and the week before with both the IJB and the strategic planning group. Some of the additional commentary I've added to the end of this presentation. So as you can see, the vision of the plan builds on our work to support people to live good and fulfilling lives. But what we've been quite clear about is that it's set in the context of today, that it reflects what we've learned from the challenges that we've faced in recent years and what we know is important to people. We want to be ambitious and innovative. However, we're planning this in a time of unprecedented increase in demand and complexity of need, with significant financial pressures and also issues in and around our recruitment and retention. We know that if we continue to deliver the same services in the same way, that we'll face a significant financial gap over the next 3 years, and that we run the real risk of overpromising and under-delivering. So we know then that we need to be transformative in our thinking, in the way that we organise ourselves, and in our approach to providing and arranging our care and support arrangements. So the priorities and ambitions and vision of the plan are taking all of this into consideration. I'm going to start back to front with this one. With the vision is that we want every person in Perth and Kinross to live in the place that they call home, with the people and things they love, in good health and with the care and support they need, in communities that look out for one another and doing the things that matter to them. The ambitions are that we want people to stay as well as possible for as long as possible. We want people to live as independently as possible for as long as is safely possible, and we want people to thrive and feel valued members of their communities. And so the priorities that run throughout the plan are based on those ambitions and visions, and they are that you value our workforce, support them to keep well, learn and develop, to target resources to where people and communities need help most, make it easier for people to understand where and how to access services, provide health and social care supports close to home, work with communities to design the health and social care supports they need, improve integrated working, and promoting self-management and living well. So the plan goes on to talk about how it came to where it is, and it gives an overview of our consultation activity and the methodology that we used. I won't go over that verbatim, we've discussed that in previous meetings, but basically a combination of in-person and online consultation activity. The plan then has a section on it in regards to the Joint Strategic Needs Assessment, roughly 3 to 4 pages with high-level data that has come from that and underpins the priorities and the intention of the plan. Both the JSNA and the consultation report and its methodology are included in the appendix of the first draft. The plan then goes on to discuss performance and the importance of performance. It talks about how we'll gather that information, and we'll use a variety of methods for that: national and local indicators, priorities, self-assessment, frameworks, audits and engagement activity. So as well as monitoring our 9 national health and wellbeing outcomes, which is a statutory requirement, the IJB must also measure its progress towards meeting the ambitions and priorities within the 3-year plan. And when I talk about the priorities, I'll describe how those national and local performance measurements will interact with one another. The detailed plan for measuring and reporting this information will be published in an IJB performance framework this year, and reference is also made to our public health priorities for Scotland and our commitment to ensuring that we play an active role in the successful delivery of these. As well as that, we also included our Health and Social Care Integrated Framework. If you recall, the Scottish Government gave a presentation on that framework, and basically it outlines the different aspects that we would want in place to ensure that we are delivering good integrated health and social care services. So it gives us an ability to audit our performance in relation to that. So the priorities, as I've spoken about before, are laid out in the plan, and each priority has a similar layout, and talks about, first of all, why the priority is important to us. It talks about what data from the Joint Strategic Needs Assessment underpins that specific priority. It talks about what the community consultation told us about that priority and why it was important to the people who live in Perth and Kinross, why it was important to our workforce. And then it tells us about what we're going to do to improve that, and then finalises in a section of, and how do we know that's made a difference? And that links into our delivery plans, which have underpinning performance frameworks. And this is the measure that we will use to ensure that both service improvements are iterative and that we're able to tie in with our annual performance reporting statutory requirements. The document will be live when it is published, and people will be able to click on the links to delivery plans so that as and when they change, you have live information as opposed to a delivery plan that might become outdated in the period of the 3-year strategic commissioning plan. The plan then goes on to talk about resources and risks and the ambitions within the strategic plan. It talks about the IGB being required to set balanced budgets, but funding's not keeping pace with increasing needs and cost, that the IGB's 3-year financial plan recognises that the IGB is facing significant financial challenge over the coming years, and that we need to be realistic about what we're going to be able to deliver, and that a programme of transformation has been agreed, which spans the entirety of the partnership's business and seeks to establish transformational change whilst delivering sustainable services and good outcomes for the people of Perth and Kinross. The next section talks about partners and their contribution, and that's threaded throughout the entirety of the plan, but it has a specific a section within the plan referring to their housing contribution statement, for example, which is mandatory in our statutory requirements when we produce a strategic commissioning plan. But it also talks about our third and independent partners and the importance of working with them and the value that we place on the relationships that we have with them. And finally, in this presentation, these are the comments that have come from the Strategic Planning Group and IGB development sessions. And there are more to add to this, but these are the ones that I pulled out as being the most predominant ones. So people commented that they would like to see even more explicit input from the third sector partners. They wanted to see technology-enabled care and how we can further embed the use of that more explicitly referenced. More reference made to our extreme rurality. Supporting carers with their role when someone is discharged from hospital in particular. They wanted us to talk about that. A thing that happens commonly to people is that they have to tell their story over and over. So they wanted something that talked about that experience and what it would be that we would do to improve that. They spoke about iterative community engagement and getting good feedback has been really important, and that we would embed that in one of our priorities. Transitions at all points of life, not just when people leave school and move into their adult life, and ask for a pictorial representation of what good looks like in case studies, and I think we'll do that in a planning cycle type infographic. Continued learning and development support for care at home and care home sectors. Good practice examples from the third sector. I should have mentioned we have good practice examples threaded throughout each priority, and we will make sure that there are examples from all of our partners. Training for our workforce in specialist areas of delivery, more widespread. Social isolation pulled out more so, and a slightly more enhanced financial section which pulls out the financing specific to specific user groups, and our Chief Finance Officer Donna and myself have been working on that activity already. And that's the presentation.
Thank you very much. Do we have any questions from members on the report? 3.
The presentation, as well as being very positive about the way we want to go forward, despite a load of roadblocks in the road and some big holes. But the question I'd like to ask is in relation to this in the budgetary journey alongside it, what kind of monitoring do we put in place? So, for example, like later in the agenda, we've got issues around care at home, hospital at home, and there's looking at we are going to be able to, as we progress with the pressures of budget on us, how do we going to report back if we've got something there as a priority? How do we declassify? What do we do?
multitasking in now.
I'm a man.
I would suggest that will come through both our performance framework and performance frameworks that sit under our delivery plans, and any decision making that would come through that strategic work, and that would feed through into, do you mean in relation to the strategic plan, how that will impact on that? Yeah. And that's why we've linked the delivery plans into each priority, so that the performance measurement and financial measurement that goes alongside our day-to-day delivery is fed through that strategic commissioning plan, so that it's live and updated. Whereas I think when you don't do that and don't create that live link, then things do become outdated, and then the strategic commissioning plan can quite quickly become irrelevant. So I would suggest that's one measure for that. And Donna, do you want to come in?
Thank you, Zoe. There's two things that go to regularly to the Audit and Performance Committee that will help us in our monitoring. One is the financial position, so that goes on a quarterly basis to the Audit and Performance Committee and will be an early indicator if the risks to our strategic plan are escalating and that we need to take action. The second thing is the strategic risk register, and I think right up front on our strategic risk register is our financial resources risk, and we are sitting at a very high status already, and that risk is identified as what risk does the IGB have in not being able to meet the objective of its strategic plan. So when we come on to the budget to discuss the budget later, one of the key considerations that we've got in the budget decisions that we make and in our financial management decisions are, is this decision contrary to the strategic plan objective? If it's not, that's good, and we can proceed. But it might be that the pace has to change, and it might be that we have to pare down what our hopes were. But we will monitor that regularly via the Audit and Performance Committee and reporting to the IGB.
One other point to address that. Would that come back to the committee to make decisions? You might have 2 or 3 different choices to make in terms of service and service deliver. Would the expectation be come here back?
Thank you. It's a good question, Ian, because we are required to report annually on our annual performance. So you would be at least having an annual report on that. But as Donna was saying, there'd be quarterly reports that would be coming through the Audit and Performance Committee. I was going to say, thinking glass half full, it also allows us, if there was other funding opportunities that came along the way, to ensure that we're targeting that in terms of the strategic direction of the IGB. So I think that linking of the strategy, if you like, and the financial strategy and our transformation programme, which is about redesign and efficiency, bringing all those together is absolutely the right thing to do. Thank you.
So are you actually saying then that it's going to be annually, instead of annually monitoring, you're going to report quarterly then? Because I just wondered, do we have a plan B? Because the financial restrictions are such that, you know, we might not be able to, you know, carry out, you know, what's in the plan here. And how soon will we rectify it and let it be known to the rest of the IGB?
The reporting that goes quarterly already happens, Maureen. It happens through the financial report and the performance report that goes to the Audit and Performance Committee on a quarterly basis. What we're saying, we would use that mechanism to flag the risk, whether that be a financial risk or a performance risk, to the IGB, and then take that report to the IGB if we needed to take an action for them to make a decision.
Thank you. And just to give assurance to Maureen and IGB members that as a management team within the Health and Social Care Partnership, we will be looking at financial reports monthly, and we will develop a performance framework that aligns with that too. Thanks.
Mr. Black.
Actually, the report going out was really great to see so much consultation. That was really impressive. But I noticed on one of the slides in the bottom right-hand corner, it says 75% of the responses came from women. Does that mean that we need to start targeting groups for men to respond to that and get some equity in there.
I think that's a really good point, Martin. I think it highlighted that women were more interested in being engaged in the activity than men were, despite the biscuits and glamorous women that we tried to seduct them into halls, etc. So, yeah.
Are there any more questions on the report? Vice Chair.
Thank you. Thank you. I don't have a question, but what I did want to say is that I really enjoyed how the plan brought the different bits that you're talking about together, not just the links that you'll be putting in that are live links, but the engagement that Martin talked about, the views of our communities, and how that linked up to the ambition that we have for our population. And I really enjoyed how it was laid out, and I enjoyed the feeling of humanity that came from it. And I understand that you didn't do this in this presentation for all really good reasons, including the succinct word that Colin mentioned. But actually, it's a good read. It does show care. So thank you.
Thank you. Any more questions or comments? Okay, so the board is asked to note progress made to date to prepare the IGB strategic plan as outlined in the report, and agree that a final version of the Perth and Kinross strategic plan will be brought back to the IGB for approval at our next meeting in June. Can we agree that? Thank you very much. We'll move on to item 7.4 on the agenda, which is our Autism and Learning Disabilities Strategic Delivery Plan update. To introduce the report, we have Kenny Ogilvie as the Head of Adult Social Work and Social Care, and Gillian Morrison, Service Manager.
Thank you, Chair. This report provides a progress update of year 2 of the Autism and Learning Disability Strategic Delivery Plan, and the plan runs from 2022 to 2025. I think it's just worth noting that this is one of the strategic delivery plans that sits underneath the strategic commissioning plan that Zoe was talking about. And again, it gives us practical examples of how we're deploying our resources, we're monitoring the impact of those resources, and making amendments as required. So with more details, I will hand over to my colleague Gillian Morrison, who is our Service Manager for Autism and Learning Disabilities.
Thank you very much. People hear me. Thank you very much for that. I would just like probably to just highlight some parts within the report of what progress we've made over the last year. One of the main areas that we've worked on is around the development of our scope team, which is supporting young people and adults with a learning disability and or autism who have complex care requirements. And so the scope team is now fully staffed bar our OT post. However, I can give a positive bit around that in regards that we now do have funding to be able to support that post, which is a 0.6 full-time equivalent OT, and that's currently out to advert, so hopefully we'll be able to fill that post in the near future, and that will support the ongoing work within the team, especially around a discharge of long stay hospital admissions, because a lot of that work will be around sort of environmental needs for people within their housing options in core and cluster. What we have noted over the last year within the scope team is we've had an increase in the number of people that we've support by 10%, which highlights that continual increase that we have around the complex care requirements for the individuals within Perth and Kinross. And that again reflected around supporting young people through transition. So we supported 24 young people last year into adult life through the scope team, and that was done in a multidisciplinary way, including input from our family group decision making coordinator, and we recognise the value of that role. And actually what we're going to do going forward is to ensure that all young people and families and carers are offered family group decision making at that very start point within their transition pathway. So we all supported one person out of our long stay hospital last year, which is noted through the reduction in our bed days, and we're planning for a further 3 in 2024 and 25, and there's ongoing active transition planning going for those 3 individuals at the moment. We endeavour to take a multidisciplinary approach to enabling in regards to supporting individuals to remain in the community to reduce the risk of remission into hospital and long stay residential care. And I've got a couple of examples around how we've managed to achieve that within the team. So we had one young person who was living at home, had transitioned a couple of years ago into adult life, was at home, was quite complex care requirements. Parents were really struggling to be able to support, and a result of that situation was breaking down. And we didn't actually have a ongoing solution for her, so we supported her around using our outreach workers to support that package of care until we did be able to secure a supported accommodation locally, and she's now moved into that. That's going well, and it just shows how we've managed to stop out of area placements as regarded that, making sure people are remaining within their own community. We also, through the work of our psychology input, there was again a risk around a breakdown of provision locally, which meant that young person was going to have to move out of area, and input from psychology again enabled that person to remain within their current provision and remain locally. So it's just kind of a couple of examples of how that work is ongoing and supporting people to remain locally and have their needs met appropriately. And that takes me on to our requirement now of May 2022, we're required to provide submission to the Scottish Government under the Dynamic Support Register in regards to people that are in hospital, placed out of area inappropriately as well as appropriately. And we've done 2 submissions to date, which was October and January, and we've got a further one in April. So they're quarterly returns, and we have set up an oversight group within Perth and Kinross, which we meet on a monthly basis. And again, that's a multidisciplinary approach to look at how we're supporting those individuals who, particularly the people who are on the red and the amber of that register, to ensure that we're finding solutions for them, whether it's in long stay having been in long stay hospital or an out of area placement that's not appropriate. So moving on from what we've been doing around sort of complex care, looking around the wider learning disabilities and autism, we are supporting individuals into day opportunities through our in-house day opportunities as well as external, and through our fund network. And we've noted an increase in the number of people that are accessing that service, which is really positive because people are accessing meaningful activity within the local own area. However, that has raised issues that we're getting to capacity. So as a result of that, we're looking at how we can improve that. So we are looking at what the current service is looking at and how we're providing that, and what we need to do to move forward to ensure that we're able to continue to support people as they come through, especially for young people that are transitioning. And in addition to that, we're looking at how we can engage with our communities so that people can access actually local ongoing groups as well. So they're in that inclusive approach locally. Around the transition work, we had done some work around how we better support individuals who are transitioning, and one of the areas that was noted was sort of having the right information at the right time through that transition pathway. So nationally, there has been what we call the Compass app that has been developed, and we've taken that forward locally. So that will enable young people, parents and professionals to have access to useful information and support their transitions. So that's in the process of being rolled out, and we're doing that joint piece of work with our education colleagues as well as our third sector. And we're hoping that that will go live in June this year. And we have had an exciting opportunity around ensuring that we are able to hear the voices of our local people with learning disability and autism through funding we got through the Angel Share, and we're looking to get a dedicated facilitator to support that work as well. So again, it's about ensuring that we're hearing the voices of those that we're needing to support. So we've also done a joint piece of work with Perth and Kinross Council around and the third sector around how we improve employment opportunities within Perth and Kinross Council itself, and that's been around a training opportunity for recruiting managers to have a better understanding of how of people with autism and how they can be better supported into employment. So that's been an ongoing joint piece of work. So again, working with our third sector in regards to that. In regards to technology enhanced care, we have been doing work around delivering an overnight responder service, and that went live on the 29th of January. Currently, it's a test of change we're undertaking, and we're supporting 5 individuals with initially it's planned to review on the 29th of April. So it's looking at as a 6-month test of change. In regards to the ongoing health needs of the client group, we are looking at how we can address the inequalities of those with a learning disability through our learning disability health services, and through the annual health checks, which is now a requirement from Scottish Government. There is a Tayside-wide strategic group looking to how we deliver that Tayside-wide, which is still ongoing. However, locally, we have already undertaken work to provide health checks, which not covering all aspects of the annual health checks checklist. We are actually undertaking work around that, and in the last year we have supported 74 health checks in respect of that, and that's ongoing work locally by the LD health team, and we provide a number of different clients, clinics within the LD health service, and which include ADHD monitoring, clozapine and Down syndrome screening. We've also implemented a postural care clinic in line with the postural care strategy requirements. We also, in addition to the work we're doing around the annual health checks that are Tayside-wide, we're also linked into the Tayside-wide Mental Health and Learning Disabilities Whole System Change Programme, and we've had reps attend the workshops that were ongoing last year, and there is a plan to have rapid improvement design sessions in April as well, so we will have reps from Perth and Kinross there in regards to that. In regards to, so currently we don't have an autism strategic plan, that's because that came to an end in 2021, and we went out to consultation at the end of 2022, and one of the main areas that was highlighted within that consultation was around mental health for individuals that are living with autism. And they really saw that as their highest priority of how it can support around their mental health, being able to access mental health services was really important to them. So as on the back of that, and we've done some work to develop a couple of workshops to look at that more in depth. And we just had our first workshop last week, and we've got our second one actually tomorrow, and we'll hopefully be able to get some really rich information from that work. That consultation has got a mix of third sector, health, social work, education. We've got those with lived experience and also carers as well. So it's a really wide, I think we had 50 odd people at the workshop last week, which was really good. So just coming on to the financial situation, we do recognise that we do have an ongoing pressure of 1.5 million, and that is around that increased demand, which I spoke about earlier, and around the complexity. So we recognise that it's ongoing, and how we best do that to address that that ongoing demand, and that comes through the work we've been doing through the Complex Care Transformation Programme, and how we develop services which are financially stable, sustainable, while improving the lives of those we support. And as the strategic delivery plan will continue to strive to meet the needs of people whose support requirements are recognised, and recognising the demand, the pressures that we've got. Thank you.
Thank you very much. Do we have any questions? Councillor Frampton, you're first.
Thank you for the report. I was looking at 3.3 of the independent living, and the number of units that's either in place or, you know, in the process of going in place. I was wondering, is there to be more units in the future that's going to include areas that are more rural, such as Kinross, Pitlochry and Dundee? Most of the units seem to be Perth focused, Perth city centre. And I think that might exclude a lot of people that's living in the rural areas from this, independent living. Thanks.
Yeah, thank you for that. Yes, we recognise that a number of the sites have been around Perth City, and we are actually at the moment in consultation around some work in Aberfeldy, and we'll continue to look around our rural areas. We work closely with our housing colleagues, and it's where new developments are coming on board. We're having those conversations around those new developments. Is there opportunity to develop a quorum cluster within that? So yes, that would take into consideration the rural communities as well.
Councillor McCall.
Thank you, Gillian, for the report. I have a few questions if Convener is nodding. Okay. It's very comprehensive, so thank you very much indeed. My first question is on page 26 of the report, section 3.1, concerning 24 young people transitioning from adulthood to adulthood who left school in 2023. Are they all from a specialist school, or are they across a range of schools?
No, it's from, so a number of them do come through for our specialist school, Fairview, but no, we are linked into all our high schools within Perth and Kinross, and we have a link worker from the Scope team who are linked into each of the high schools and linking. What we tend to do is we get updates from the high schools on sort of towards the end of the summer term, and also into January, to make sure we're picking up the individual young people who are coming through and will required enhanced transition.
So are these young people who have received a diagnosis of a particular mental health issue, or is it just people with additional support needs, or is there some criteria around that?
So for transition, yes. So every young person who has an additional support need is entitled to a transition pathway. We support around the enhanced transition. So there's different levels. There's universal, can't remember what the middle one is, and I do apologise for that. And then we've got the enhanced transition. Yeah, so there's different pathways.
Silence me. That's good. Thank you very much. So my next point is on page 29. Just bear with me till I find it. On section 3.4, support people with learning disabilities to participate in their communities. This is a long-standing ambition. I think most people who are involved in this area would agree. And we talk about making sure that their voices can be heard, but I'm just wondering what we're doing to make sure that communities can listen.
Yeah, that's the difficult bit, is getting to communities. So we have, we're doing a bit of work at the moment with Let Them For All and also the YMCA in Perth to see if we can start linking into some of the groups and so that people can access what would be, I suppose the best description is mainstream groups rather than specific groups for people with a learning disability or autism. So it's trying to ensure that one is accessible for the individuals, but also that the groups themselves are accepting and able and are willing to support those individuals when they come into the groups.
Thank you. So even though I'm a trustee on Let Them For All, I didn't know you were having those conversations, but I'm very pleased to hear it. But that's exactly the sort of thing that there are others, and I think, going back to Councillor Frampton's point, there's probably lots of community groups in the more rural areas as well. And I think there's also a route there for social prescribing opportunities there too. So I think that's very encouraging. My last question, if I may, it's really just a point of clarification. It's again on page 30 on 3.9. You say work has commenced on a multidisciplinary dementia post-diagnostic support pathway. And it says for those with a diagnosis of learning disability and dementia. Is that a learning disability with dementia, or is it two separate cohorts?
People with a learning disability and have, it's in one of the, I don't know what I've done with this. Yeah, what we wanted to ensure that people have got the same post-diagnostic pathway as people that don't have a learning disability. We've recognised historically that people with a learning disability haven't had that opportunity to have post-diagnostic support. It's a dual diagnosis, yeah, sorry.
That's what I was trying to get, because some other reports that came, maybe not before this committee, but other committees have conflated people with a learning disability and people with dementia. So this is people who already have a learning disability, but they now have dementia as well. Okay, that's clear. Thank you very much. That's all, convener. Thank you.
Thank you, Mr. Black.
Thanks for the report. And just a question on 3.11 on page 31. You're talking, I'm presuming, I thought I heard you say, is this a local consultation that had taken place in 2022? Right, and then it further goes, recent statistics show that people, so there's been another consultation or more information gathering. And then the bit that alarms me and frightens me quite significantly that 9 people are 9 times more likely to die from autism. And that to me is quite frightening. So in comparison to national statistics, how does the local consultation fare? And is there any evidence nationally that this figure is lower? And lastly, in the workshop, I'm glad that there are workshops, but will there be an element of alerting people to suicide prevention?
Thank you. So that was a national data rather than a local data that was that I provided, and the consultation was local consultation that we did in 2022, to sort of on the back of the autism strategy coming to an end. It was like, let's start looking at what are the priorities for Perth and Kinross individuals that have autism. So yeah, that was that work. And then on the back of the consultation in 2022, we've developed these workshops looking at the main priority being around mental health, because that was what was coming out as from local people as being the main concern. And obviously the national data is also saying that is significant. So we could see both nationally and locally that that mental health and autism, go hand in hand, and mental health is often higher for people with autism, and therefore we want to look at how can we better improve the services locally to enable people to have their mental health needs met, and that is across. We recognise there's lots of barriers around that, and that's about being able to access the services as equally so as mental health services, understanding what the needs are of people with autism as well. So it's kind of both ways about how do individuals with autism access the service, but also how do services ensure that they're getting it right and making their services accessible as possible. So that's the work we're on that, starting that journey just now, and we're hoping from the information we get from the workshop we did last week and this week will start to give us an idea of what we need to do locally to improve that for individuals.
Thank you, and Mrs. Auld.
Thank you very much. And again, congratulations on a really comprehensive report. My question was actually very similar to Councillor Black's. So it was the same point. I also was really shocked at the statistics of people with autism being 9 times more likely to die by suicide. I just wondered, it would have been, so when I saw that, I wanted to look at the reference, I wanted to look at the stats that was based on, so it would be really helpful if that could, the reference which those statistics were based on could be shared. And also I'm conscious of the suicide prevention strategy that's being developed and implemented just now. And so on the back of that statistics, I wondered if how we were particularly targeting our autistic population to involve them and make sure that they are able to access the prevention work that is going on. Thank you.
Okay, thank you. I think Mrs. Robertson, do you want to come in? You've dropped I think a reference to the report in the chat for members, but if you want to come in.
Yeah, the Suicide Prevention Action Plan is currently being drafted and is due, the first draft due to go to COG in June in actual fact. And off the back of that piece of research specifically, we engaged with Perth Autism Support and Autism Initiatives in Perth and Kinross to ensure that they were threaded through the middle of that delivery plan and those statistics in relation to autism and suicide. It's not new that autism and mental health are connected to one another, and we've known that for quite a long time, but those particular statistics were quite alarming. So that's the work that we're actively progressing just now.
Okay, thank you. Thanks very much.
Thank you. And I'm going to presume that COG is Chief Officer Group. That's all right. Mrs. Hamilton.
Thank you, John. Thanks for the paper. It was really comprehensive. It was a good read. But one of the questions that came to my mind, we've talked a lot there about autism and the issues around autism. I know that nationally they're looking at the autism and neurodivergence issues and strategy. I was just wondering if we've got that on the radar about autism as being part of the neurodiversity agenda.
So you're probably aware that there is the bill at the moment that's out for consultation. Yes, so for short, LDAN, as we're being able to go to the Learning Disabilities, Autism and Neurodivergence Bill. It's a bit of a mouthful to put out, so we're shorthanding it to LDAN. So actually on Monday, just past there, we have done some local consultation in respect of that. So we had about 20 odd people came along to that. We're looking at so we're gathering it that, so that was at that particular consultation. We're also doing work through our strategy groups as well to put back consultation in regards to that bill. And yeah, the definitions and what we're going to describe as diagnosis, I think, still up for that's part of the consultation at the moment. Who should be included in the bill? How should we what's the terminology around that? And those are some of those questions that we were actually asking and discussing at the consultation group on Monday.
That's great, thanks. I'm just aware, as Jackie will say, we're aware of this work that's increased dramatically within children's services, and obviously it will have an impact in adult services as well. Yeah.
Sizable neurodevelopmental weights. Be really interesting to see what impact you're seeing from them.
Just generally, and I suppose a statistic is that when we brought the transition team together, or the work we were doing around transitions back in 2012 into 14, which was originally a pilot, we were looking at 10 to 12 young people transitioning year on year. We are now looking at 20, well, this year was 23, 24 young people. So we've doubled the number of young people that we're recognising with complex care requirements, and that obviously includes those with learning disabilities as well. But yes, so if that's what we are looking at in that small cohort of individuals, then yes, we can see there's a massive increase in young people. And I was also at some work around around the ASN approach with education. I went to a workshop around that, and again across the board they're recognising the increase around additional support needs for pupils, which a lot will be around the neurodiversion, ADHD and autism, and there's a wide range around that. So yeah, definitely seeing big increases. Mm-hmm.
Thank you. And did you want to add something, Mr. Roble?
Thank you. Yeah, I would just want to say that we have recently reallocated funding for 2 dedicated posts in our community mental health team to support people with neurodivergent conditions as well. So, that will be a reasonable amount of extra capacity to try and support people.
And Mr. Henderson, Dave.
Thanks, Gillian. Just touching on 3.A that tests the change for the overnight responder. Brian Kinnear within the partnership and myself started a supported living providers forum back in January, meets quarterly, and as part of the agreed agenda, technology and new models of care. So it's internal services and independent providers. So this will be a great opportunity, because the forum's just started, of going on this journey with the test of change, to have peer discussions and see how it can affect both the internal services and the independent providers as it goes through the test of change. So it's a great opportunity there. So just like to comment on that.
Yeah, thanks for that, Dave. Yeah, I mean, from the very word go, when we looked at doing the overnight responder service, we involved our third sector, our providers in regards to that, and that's going back pre-pandemic. That's how long ago we started this journey around overnight responder service. Currently, our triage response is an in-house service that we're delivering. However, we recognise as we go to roll out the service wider than our test of change within Perth and Kinross, that we will be looking from involvement from our providers as partners in that, to be able to deliver direct support if required, because the main way we would want to respond through the overnight responder is that virtual response, but we'll always recognise that sometimes people will need direct physical intervention during the night, whatever that might be required, and therefore we wouldn't be able to deliver that just from one site. So it would be about being able to look at, again, looking at the rural aspect of it around, local providers in rural areas. Would they be able to provide that direct response if required? But the triage would still be centrally based for that virtual initial response. If it needs a direct response, then it would be, we were looking at our local providers coming on board and being part of that. And we're already in discussions in regards to that in the project we're doing up in Crieff with the provider there. They're seeing that again as a hub that they could potentially provide that overnight response to sort of an outreach from that service. So already those conversations have started in respect of that.
Thank you very much. I'm looking round for the last call for questions or comments. Chief Social Work Officer, Mr. Singh, please.
Thank you, Gillian. Really comprehensive report. So thank you very much for that. Gives a real flavour of the work that's been done across services. I suppose just an interest around transitions, which you spoke about quite comprehensively, from children's to adult services. Clearly, we recognise that's a really stressful time for families from all the research that's been done. I'm just wondering, are we touching base with individuals, parents, carers throughout that transition period to see what their experience is, to see whether or not we need to strengthen any parts of the pathways?
Yes, we are doing that. We are having conversations with parents and carers, and that's where some of that work came around, about the linking around the Compass app, that importance of them having that information. What we want to do is we would like to get better at that as well. And I think through our family group decision maker, we will be able to do some of that work as well and get the feedback of what that experience is like through that. She's already doing that through the work she's doing. She has a feedback sheet on the experiences of using family group decision making, and we would want to try to roll that out further as well.
Thanks very much, Gillian. I just wondered if it would be helpful to outline for IGB members what family group decision making actually involves. And I know, and succinctly, to use the chair's encouragement.
I'll try and do it as succinctly as possible. So it comes from Children's Services, so that's where the model come from originally, and it's a strength-based approach. So it's about basically saying families, person, the individual, they know their situation best, and it's about providing that space and opportunity to allow the person and their informal network to come together to look at what are the issues, what are the concerns, where are the barriers, and then looking at the bit around what can they do, so what's within their own network that could be able to cover some of that, and what supports they've already got that could support around that, and then looking at where the gaps are and where we can come in as from a statutory point of view. So it's very much around that. It's advocacy in its best form, I suppose, and it's done through a conference approach, and there's a lot of work by the family group decision maker beforehand to kind of build up information, speak to the individuals, because often people don't actually think about what their network is until you actually start asking them, and then they actually say, oh, actually the neighbour down the road is really helpful, and it's just looking at what people's networks are and how they can best support. And we've had some really good success in respect of, you know, somebody saying, actually I could provide that transport and not having to pay for transport costs. So that's kind of an example of that.
Thank you. And Mrs. Summers.
Yes, we spoke quite a lot about the transition from young people to adult services, but now that people with learning disabilities and autism, etc., are living much longer, the 4 people that you said have been diagnosed and treated in Tayside, are they of an age where they're actually POA stage, or are they under 65?
Good question. Can't tell you off the top of my head, and it's difficult to say because we do know within learning disabilities that, and especially people with Down syndrome, are quite often are under 65 diagnosis around dementia. So we do know that. So I can't actually tell you off the top of my head if they're over 65 or under 65 because I don't have that information. But yeah, and I think it's that important bit of recognising, as you rightly say, that people are living longer, and how do we adapt services to meet those individuals' needs as they grow older. And we're finding that already. We're starting to come up against that and saying, actually, we potentially don't have the right resources, so this is giving us this opportunity to look at that and saying, what do we need to do and what services do we need to develop and deliver in, you know, along with our private sector, third sector colleagues in respect of that.
Just been told to go ahead. It's sort of following up what Maureen has said there. It's on section 3.9 in health developments about access to healthcare. And I think this is actually a really important point. I know that, you know, because learning disabilities is such a wide spectrum, and actually there's a difference between mental well-being and mental illness as well that I think we need to understand. But access to healthcare is indeed, I certainly know from the one area I know most about Down syndrome is very patchy, particularly to GP services. So it's maybe something we need to consider. I know that at least one GP practice, when someone with learning or with Down syndrome reaches the age of 40, will invite them in for a proactive health check, but not all GP practices do that. But it does mean that if something is, you know, likely to develop, a health condition develops, then at least they have some records and some history and they're able to respond much more quickly. So I think if whoever's, somebody from the GP is not here today, if somebody from the GP service, oh, you're there, yes, sorry. I think it's something worthwhile taking up, particularly for those people who may have difficulty communicating how they're feeling as well. Thank you. That was mixed up. It's not really a question, it's more a comment. Thank you.
Okay, thank you. If there's no more questions or comments. Just one very quick one from me. So one of the recommendations is to bring back an update in 12 months' time, but I noticed that there is the strategic delivery plan for 22 to 25. So next year we'll be starting the process of bringing in a new delivery plan.
Yes, so that'll be our final update in 25, and then we'll then have a new strategy going forward plan.
Thank you. So can we note progress to date on the Autism and Learning Disability Strategic Delivery Plan and request an update in 12 months' time? Is that agreed? Okay, thank you. The next item on the agenda is the IJB budget for 24 to 27. I wouldn't normally take a break after just an hour into the meeting, but we might spend some time on this one. So I would propose that we come back at 2:15. So 10 minutes just to stretch our legs before we sit down and spend a while on the budget. Thank you. Okay. Thank you very much. Item 8.1 on the agenda is the 2024 to 2027 budget from Donna Mitchell, our Chief Finance Officer. I would say that the budget that we're pleased to present today is the culmination of a series of IJB development sessions. I know you'll touch on this, Donna, but a series of IJB development sessions and budget review group meetings for the voting members of the board, and there's been plenty of robust questioning and challenge throughout this process. Chief Finance Officer, would you like to introduce the budget?
Thank you, Chair. Before introducing the report, I would like to thank the people that have helped to bring the budget to the board today. Firstly, I would like to thank the managers of the Health and Social Care Services for their insight and their valuable contribution into this budget process. I would also like to thank the Health and Social Care Finance team, I think there's a couple of them online, and the Executive Management team for all their work and preparation. I'm also very grateful for the support from human resources and finance teams from both NHS Tayside and Perth and Kinross Council. You can tell it's been a very much a team effort to bring this as an informed 3-year budget. But I would also like to thank the IJB members for the considerable time that they have given to the budget development sessions, and to voting members that have met as part of the budget review group. There has been, as Colin said, significant amount of time, scrutiny, challenge and consideration that's been given to both the proposed pressures and the proposed savings and reductions that are included within this report. The financial challenges facing the public sector, and therefore the IJB, has made this one of the most difficult budgets that we've had to prepare. And I thank you all for giving the level of advice and focus that you have. We're all aware that funding is not keeping pace with increasing needs, the complexities and the costs, and it means that this IJB does have the difficult challenge of trying to balance an ambition to achieve strategic plan priorities for the people of Perth and Kinross, whilst meeting the requirement to balance the budget. This IJB collectively needs to set the tone that financial management is core to us achieving our strategic aims, and to demonstrate that public money is being used well. In recognition of what this may mean for services, we've taken forward engagement with various stakeholders, and this has taken place through this budget cycle. This has included meetings with service managers, with human resources, with trade unions, with staff side, communication to all health and social care partnership staff, but also specific briefing meetings with services and staff that may be impacted by these proposals. I'll now move on to the report, but I don't propose to go through all the report and appendices, but I will highlight the key messages of the report. The budget delegated to the IJB from Perth and Kinross Council for 24-25 has been confirmed, and it was approved at Council on the 28th of February. There is no recurrent uplift from Council, but they have passed through all Scottish Government funding relating to living wage and free personal care, and the Council has also approved 800,000 of non-recurrent funding to support the delivery of the transformation of care at home. The budget delegated from NHS Tayside does remain indicative at this stage, as the NHS Tayside budget is due to be set on the 25th of April. Therefore, an assumption has been made that recurrent funding will be equivalent to that of 23-24, and any pay uplift provided by Scottish Government will be passed through in full to the IJB. I have noted a risk in Section 8 of the report due to this still being a draft position. So therefore, neither the Perth and Kinross Council or the NHS Tayside delegated budgets provide any additional funding or uplift to offset inflation or cost or need increases. So in taking the budgets from Council and NHS Tayside and comparing this against the forecast pressures and expenditure next year, it gives the IJB a savings requirement of just under £9 million going into next year. And this is equivalent to a 5% saving, and that's 1 year. The proposed savings and reductions to go towards meeting this gap total £5.5 million. These are detailed in Appendix 2 of the report. Therefore, this means that even with all proposals, we remain unable to balance without the use of reserves. And the IJB is therefore asked to approve £2.3 million of reserves to deliver a balanced budget next year. This will reduce the IGB's general reserve to 1% of the budget, and this is below the aspired 2% reserve policy level. The use of reserves is obviously one-off, and it means that the gap rolls forward to the next year. The 3-year budget is not yet balanced, and if no additional funding is allocated to support health and social care, then there is a forecast £4.7 million gap by the 3rd year of this financial plan. The report's been structured to take us through each stage of the budget process, and that begins with acknowledging that this level of change is going to require a robust financial strategy. This strategy is focused on making the best use of our resources. It's the focus of this budget to ensure that we've got efficient and effective services being delivered. There was a significant amount of investment going into services over the last 2 to 3 years, and just over £8 million into older people's services alone in the last 2 years. So we must ensure that this investment has been evaluated and that we're assured that it is delivering value for money. We also have an ambitious transformation programme that recognises that some services do need to change, that costs and needs are increasing, but finances and workforce cannot keep pace. Therefore, to achieve equitable and sustainable services, we will need to transform. However, when we're facing this size of funding deficit, we must recognise that we can only be so efficient and transform so much. Then we do have to consider prioritising funding and making reductions and difficult decisions that will impact on service delivery and performance. So from now, the Budget Review Group will meet very early in the new financial year to consider additional proposals to reduce expenditure and to reduce the gap. And as discussed in the refresh of the Strategic Commissioning Plan, the financial climate means that we must remain realistic around what we can continue to do and at what pace. But we know we must be transformative in our thinking and our approach to providing care and support. Also, as noted in the strategic plan, part of the solution will include strengthening working with the third and independent sector, but also with other services and departments in Perth and Kinross Council and NHS Tayside. The challenges we face cannot be resolved by health and social care alone, and with all public sector facing financial difficulties, we will need to work closely with each other to design sustainable services. But thank you for your time, and I'll pass back. Thank you.
As an addendum to the introduction, thank you, Chief Finance Officer. The Chief Officer, please.
Thank you very much, Chair. I'd like to say a few words of introduction in relation to the proposal on page 58 of your document pack, and that's the proposal that relates to a review of the IJB's recent investment in hospital at home services. I'd like to advise the board that this is not something that we would wish to do, but this comes forward as a proposal after considerable consideration of all possible options. It may appear counterproductive to the IJB's ambition and commitment to innovation in addressing the needs of the Perth and Kinross population. However, it is clear that this model is not sustainable in the current financial context. It is brought forward today following a risk assessment which noted that this results in minimal impact to both patients, service users and to staff who will remain in the employment within the Health and Social Care Partnership and NHS Tayside. Evelyn Devine and I met with the team yesterday and provided assurance and support to them. I agreed to provide to the IJB information that the team felt related to inaccuracies within the documents that you've been provided in advance of today. So yesterday evening I provided that to members of the board in writing, but in the interests of transparency I would just like to read those out to you. So the service is described in the papers as a standalone service, and it is described in this way because it has its own management arrangements, and the wording is not meant to indicate that the services operate in isolation, and we would want to ensure that you're aware that there are close links to a wide range of healthcare services. The team, the hospital at home team, also wished to indicate that their work had progressed beyond a pilot phase, and it was perhaps, in my words, more accurate to describe the current activity as start-up. The service has been aspiring to virtual bed capacity of 10 beds in Perth City, as set out in the documentation. And the team would wished the IGB to know that beyond the pilot phase and from August 23, there were days in which it had achieved up to a maximum of 6 beds, but still an average of 2 to 3 beds per weekday. So the original information that we provided to you in relation to a maximum of 5 beds related to the period 30th of November to the 24th of February. So it's 30th of November 23 and to 24th of February 24. And that was the information that was reported to Scottish Government in order for us to draw down the funding that was awarded to the end of March. In addition to that, Evelyn and I met with medical professionals in acute services last week, and we'd like to assure the IGB that we are committed to regular interface and integrated discussions and with senior officers in acute services, particularly on the PRI site. And over the next year, we will continue to meet with them on a regular basis as the landscape for health and community services responds to the financial challenges of all the IGB and NHST side and the council. So the first meeting will take place next week. So it's just to give assurance that we are engaged in those interface discussions. Thank you.
Thank you, Chief Officer. Do we have any questions or comments on the report before us today? Ms Hunter, please.
Thank you, Jackie, and thank you for detailing what we had discussed within the engagement session yesterday. It's just to say thank you for that. I think the staff will appreciate you doing that today. Thank you.
Thank you, Serena.
Thank you. This will be probably one of a number of scrapes that we'll have along the road we described earlier. But having said that, we also discussed in previous meetings the importance of total transparency in terms of the consequences of decisions that are taken. And myself and others, no doubt, have had 3 letters from different people, aspects of either working in the system, a medic, and somebody who I think is a student, but maybe not quite certain. But they all make the point, and I think it's a point that we ourselves must take into consideration. For example, given the honesty in this about the strategic nature of hospital at home, it's been going in many places for about 15 years. It's not a new concept, although it is a new concept, obviously, in places like ourselves. But given it, we believe it's an appropriate vehicle for change and transformation. Should we not still have in place some way of getting the benefits of transition from where we were to where we've got to? For example, the number of delayed discharges, I'd be interested to know how many of those, because I'd imagine it's more than 5 or 6 a week, delayed discharges, and therefore the cost, the ongoing cost, because they were considerably higher than hospital at home. And secondly, it would also bring us into a situation where discharge is not effectively being improved. We could have a situation where we're going to have further situations where people are unable to get access to hospital beds. And I think we should be looking at the situation in relation to that. The second area I think we should maintain and look at is the work that's already been done in respect of the excuse me, the recruitment of staff and skills. And I think this is an area that we should be careful of not disrupting, if I can put it that way. This is an area of work which benefits improvements in staff skills, knowledge, and integration between health acute and secondary. And I think we need to look at how best we continue to encourage people to stay in a way that continues to improve people leaving hospital at the appropriate time and staying to their home. This brings into highlight something else, and it'd be useful if it was in the report. The curious thing is that the government have indicated this as a strategic priority throughout Scotland. We're all faced with the same situation in terms of hospital at home. And that's not a criticism. I welcome the move to hospital at home. But it does mean that we've got a national commitment. We've done and invested in staff, time, consultation to create a new service. The new service has been started. Yet, in terms of the funding to maintain that into its next phase, as it were, there's 3 phases, aren't there? The phase 1, which is the pilot. Phase 2 is what I think we're in now. And then phase 3 when we're fully operational. Now, I think we should at least record this and approach them. I think there's a duty of care here to us and to our patient clients. You can't ask them for a priority service to be built from scratch, opened up, and then turn the tap off, which for them is a very small, insignificant figure. The reality is. And I think we should be able to go and say, look, you've got to protect this new service. You've got a duty to do so. Having asked us to do it, it's your priority. We've complied, and with us complying, we're, for one reason and one reason only, saying it's not cost effective anymore. What we really mean is that there isn't the money. The money isn't there to do it. It's not about cost effectiveness. This is about finding a way as easy as we can to remove a service which was our priority only weeks ago. And I think we need to look at this in a way that we protect the staff and their commitment to, I don't mean redundancies, but they give a lot of their intellectual and social commitment to doing this type of work. And I wouldn't want an incentive given to them to then leave and go and do it somewhere else. And secondly, alongside of that, I thought we would still be looking at some point to increase staff in this area of primary care. And so I know I don't have a vote and I can't move anything, but I do think we have to seriously consider saying to the ministers in quite firm terms, this is not what we expect. We expect them to take the commitment and restore this resource. It's a national strategy, not just a strategy for Perth Kinross. It's a national strategy. We've been asked to pay the price, or should I say, those who we care for have been asked to pay the price.
Thank you, Serene. I mean, I'm conscious that the Health and Social Care Partnership received the pilot funding, but as you say, that hasn't been baselined in a recurring fashion into our budgets. But I know that there were discussions with Scottish Government recently about that, but perhaps if you want to cover the point about the costs and maybe touch on any other matters, Chief Finance Officer.
Thank you, Ian. I think you're right about the question over it being cost effective versus the fact that it's an additional cost to the IGB and one that we cannot afford. We're not quite at the final point of being able to determine if it's cost effective, because as you say, in this startup period, it's not cost effective at present, but fully implemented, it may well be cost effective. However, because the service is a 5-day service, there are additional costs to ensure that the service is managed, or the people are managed at home when the hours of the hospital at home is not available. So there are costs in addition to those that are during the hospital at home hours. But I think the main point is that this is an additional cost to the IGB, and one that, as we've laid out, we can no longer afford. The point that the Chair was making in regards to the Scottish Government is we had a letter from the Scottish Government very recently in regards of this non-recurring funding that we had to help us over the winter plan period, and they have advised that because of the budget situation they cannot commit to recurring funding, and that the permanent recruitment is at the risk of the partnerships, financial risk of the partnerships, and that's the situation that we're in.
Thank you. We'll go next to Sandra Auld, please.
Thank you, Chair. I'd like to agree with many of the points that my colleague Ian has made, in particular around the need for ongoing openness and transparency around the decision-making process. And while heartened to hear about the meeting that has taken place and engagement with staff very recently, it'd be good to understand at what stage that engagement began. There was some suggestion that the news of these proposals was very new to the staff. So as I said, I'd quite like to understand when engagement with them started. And secondly, I note within the papers there's also comment regarding reassessment of around care home beds, and having been involved some time ago now with the IGB when the decision was made to cut the number of care home beds, despite the projections of the elderly population growing. Again, agreeing with what Ian has pointed out, I would hate us to be in a similar position regarding decisions made here, where a longer term or even a medium term view would be more beneficial for our population. Thank you.
Chief Officer.
Thank you, Sandra. I'd like to answer your questions around engagement with the staff, and just to give assurance to the IGB that yesterday was not the first engagement with the staff. We have to be very careful about engagement around budget proposals before papers are finalised and go into the public domain. However, the staff were engaged, I think it was the 8th of October. So where did October come from? Sorry, 8th of March. Sorry, I've got Christmas coming, haven't I? So the 8th of March, in advance of the papers going public, so they were aware of this and involved with both HR and partnership representation at that point in time. And I think we gave assurances at the development session around that had been the case. And I think I'm also indicating that there will be a follow-up discussion following decisions of today and ongoing dialogue and support for the team. It's probably important to emphasise here publicly that we as a management team have being thinking ahead in terms of decisions that might need to be made, and across all of the proposals that are in here in relation to the impact on staff and staffing numbers. We currently have, it's probably now almost 50 posts that are being held in order to accommodate some of that. So we've been doing quite a lot of vacancy management and forward planning around it. So all of the staff that we met with yesterday were informed of that possibility in terms of suitable employment. The proposal in relation to hospital at home, and I may ask Evelyn or Hamish to say a bit more about it, is not well. The model and the hospital at home service as it is constituted just now will cease, but there is a retention of the medical expertise in order that we can think about how we best use that and think carefully about it over the next few months in terms of how we retain that medical expertise in our integrated community services. And the staff were given assurance yesterday about how much we value the skill and expertise that they have and that they've developed. They're a highly trained group of staff, and that and are passionate about the work that they do. So they were informed about that, and we will think very carefully about how we can ensure that they retain those skills and use those to the best of ability within the resources that we have. Thank you. Sorry, I'm losing my voice.
Thank you.
Thank you, and Mrs. Hamilton.
Thank you. I think what you've just introduced is the potential of Evelyn and Hamish coming in, but I just like to come in and say that I agree with the sentiments, Ian, but I think that the hospital at home model is just a model that was put into place through the government strategy, but lots of other people have been using different models to provide the same kind of service. And I think in Tayside alone, both Angus and Dundee do not use the classical care hospital at home standalone service. And I think we need to be careful in our language. This is not stopping the work. It's stopping the standalone team at this point due to affordability has been one element of it. But I think what we really need to be clear is we are totally committed to this piece of work going on in some shape or format that's most suited to our services in a wider sense. But I think Evelyn would probably be able to reassure you a bit more than I can.
Yes. So yeah, we've had a piece of work going on now, Ian, for quite some time, and Amanda's actually leading, and she may want to come in as well. And in terms of looking at the integration of our workforce within all of our sub-localities, and that includes, you know, health, social care, care at home, etc., and our urgent care service as well. So, you know, it would be our intention to sort of we're in the process of redesigning all that anyway, and to look at how we can use the skills of the staff we've got by redeploying them into community services and posts that are vacant. So it's not our intention to lose that skill and the education that we've done with the staff. I think it's really necessary that we try our best to maintain that, but within the workforce that we're redesigning, looking at the skill mix, looking at advanced practice, people working to the top of their licence. So we have a bit of work to do now to rethink how that model may look, but it would be our intention to start to do that moving forward. Don't know if you want to say anything else. Seamus?
Thanks, Evelyn. I think just to add to that, just in terms of the locality integrated team approach, we've just come from a meeting this morning where, you know, our leaders around the table are very positive around where we go next. And I think, as you've discussed, that the skill set that's been within the team will be enhanced and be part of that locality integrated approach, and will enhance the service to a wider community and a wider number of people and patients within our localities. So, you know, I think it's very positive, and I think we just need to keep going in that direction.
Thank you. Dr. Robertson next.
Hello, thank you. I obviously agree with many of Ian and Sandra's comments. I'm reassured by some of the discussion that's just taken place. I think it's a very sad situation to be in when we're talking about cuts and not being able to reach our aspirations for high quality care. I hope there will be meaningful engagement with clinicians and a strong clinical voice in these decisions, these difficult decisions that are being taken. And I suppose I just wanted to acknowledge perhaps that a lot of these budget proposals could disproportionately affect older people in the population, and that is obviously a concern.
Thank you, Dr. Robertson. Councillor Illingworth.
Thank you, Chair. I'd like to thank all the managers and everybody involved in putting this budget together. I think, as everybody's recognised, it involves lots and lots of difficult, hard decisions that none of us want to really be involved in. But I'm particularly concerned that we have very, very few reserves going forward, and that leaves us very, very vulnerable to any small kind of change. But thank you for all the work you've been put into this.
Thank you, Councillor Illingworth. I think members would share your concerns about the reserves policy and the Chief Finance Officer, but with the situation that the board finds itself in, this is the necessary step, and noting as well that we have had that 800,000 extra from the council in order to transform the delivery of some of the services and make them more efficient for the future. Next is Mrs. Summers.
I just wondered that in light of the fact that care home beds have been reduced, are they going to have a rethink about that? Because I personally know someone who's been bed blocking in hospital since last July because there isn't a suitable. Sorry, you hear me? All right. Since last July because there's no suitable care home beds. And that's terrible. There's not an alternative for these people. And being in hospital is the most expensive form of care, more so than the hospital at home. So how does that add up, you know?
Chief Finance Officer.
Thank you, Maureen. I just wanted to take this opportunity before there's any further discussion to clarify there is no reduction in care home beds. The proposal to the IGB today is to very much invest in the care home placements. We've recognised that the trend is an increase in one. We spoke at our budget development sessions and our budget review group around the age of the people that we have within care homes in Perth and Kinross and the need to sustain that and the need for care home placement investment in order to make sure that the capacity and flow and all the other transformation work can take place. So it was just to be clear, there is no reduction in care home beds, there's actually investment going in.
That was actually mentioned, you know, in discussions earlier that there's reduction in care home beds. Sure, I heard that. Anyway, it's badly needed now. Anyway, we need to find more care homes to take on, you know, people with complex cases that are stuck in hospital, like, you know.
Thanks. And Mrs. Robertson, do you want to comment on the provision that's coming on stream?
So there's 2 new care homes opening, one in March and one in August of this year, one in Crieff, which is 70 bedded, and one in Glenila, which is 60 bedded. The 60 bedded one in particular, they're focusing on more complex dementia as part of that development. So that should alleviate some of the current issues that we're experiencing at the moment, but we're in negotiations with regards what the use of those beds will be. So that's really positive for us.
The other place was Crieff, and what was your? Sorry.
I'll jump in. It's called Glen, or Mr. Robertson was referring to it as Glen Isle, but it's in Ailith, which I know very well because it's in my ward, and I had a very interesting presentation when that from the developers when that housing development and care home were originally being proposed before there was planning permission or anything like that. It was a really interesting model. Next is Vice Chair, please.
I just wanted to comment on the hospital at home model was based in Perth, and I'm interested, Evelyn, in your discussion about the community model that will enable us to take it into all localities. So one of the disadvantages we had in hospital at home was the need for weekends and the fact that it was focused around Perth. I just wonder how that will be, how we can eradicate those challenges in your new model.
I think firstly what we're saying is it's not a hospital at home service that we'll be taking in to the locality. It's the locality model which will provide advanced practice. So, and that will be integrated with district nursing evening service, AHP, community AHP work, etc., and our ANP service. So I don't think we can technically say it's a hospital at home service at all, but there'll be some advanced practice that we'll work through, and Susie's nodding and Amanda's nodding, but there'll be, we need to work through that advanced practice model and what can our community teams now do at home, because they, it's not just about hospital at home. We have to make efficiencies everywhere really, and be productive and be as productive as we can. So it's about what we get from our nursing staff in terms of their ability to work at the top of their licence, and that building off our workforce at band 3 and band 4 level as well. So, and what can they do differently to what maybe a band 5 nurse did before? So lots to do, but yeah, that's what we would be looking at and are looking at actually.
Thanks, Mr. Devine. Thanks for the question, Dr. Jensen. I think that shines a light on one of the aspects that we maybe haven't touched on, which is that the service was focused and available for Perth City, but not across Perth and Kinross, and that the cost of expanding that model across Perth and Kinross would have been to give equitable distribution to all and availability to all residents would have been enormous. Mr. Black, you're the next question.
Being part of the review group, I would have to say that the professionalism shown by all the staff in bringing forward their proposals, the scrutiny and the deliberation was quite intense, and it was quite challenging at times, but it was done sensitively and courteously, and we're aware that this impact will have on some people. We're totally aware of that, but the alternatives, the impact elsewhere would have been worse, I believe. So I was a member of that and a review group, and hard as it was, the decisions were reached, I think, were fair.
Okay, thank you, Mr. Black. Have we got any other further questions or comments? Serene.
Thanks, colleagues, for the discussion so far. If we're in the position where, after the meeting, the decision taken to close this down, as it were, the alternatives, some of which is interesting, that have come up since the start of the debate, they surely should have formed a report to this committee of here as the alternatives to provide services, which doesn't undermine or attempts not to undermine the effects of the cut in budget. And I think that would have been more honest, and it would also have been more reassuring to all of us. Although I'm not looking for reassurance, we're all in the same boat here. And don't intend to try to throw MD overboard. I just find it incredible that we're in this situation. Chairman, we're going to be looking to redesign and better integrate services. Have we got a new budget for this? What's the cost of? We've got the savings here, clearly, right? But if we're going to provide a new way of delivering the service, that's not cost-free, is it?
Mrs. Devine.
In terms of the integrated agenda and moving forward with integration, there will be economies of scale in terms of productivity and efficiency, reducing duplication of assessment, single points of access for people. So within that, we will be able to look at our redesign, but there's no new funding. We might as well be quite clear about that. This is about how we're going to work smarter and looking at technology as well, and sort of that ability to work in a better way, in a different way. But I can't think we can say that there's new funding, but we will be doing, we need to look at our skill mix and, what we need in terms of our workforce planning. And we've started that bit of work already. So,
Chief Officer.
I'll just say a few words, and I know that Hamish may want to come in, because I think he might have asked to come in earlier. I'm not sure. Ian, in terms of your question about, I'm not going to answer the financial aspect of it. What I'd like to answer is that in the discussion with the staff team, I was recognising their skill, their professionalism, their insights into what might be done differently, and a commitment yesterday in terms of the dialogue that we need to take forward over the next few months, because this decision would not be impacting until July, that we would want to capture everything possible in terms of their suggestions and ideas about how their experience of working in this field could be I suppose brought forward in a different way. So it was really just to say that we will not lose their insight and expertise, and we're committed to that open dialogue.
Dr. Dougal.
Thanks, Chair. Just to pick up a couple of points. First of all, there was a comment made earlier about the high quality of care being compromised. I don't think there's any question that the quality of care being delivered will change. The way that it's being delivered may change slightly. I think that's the second thing to comment on, that only about 1 in every 100 patients who are admitted to hospital in Perth and Kinross each week go into the hospital home service. So that's the scale of it. It's a very, very small number of patients who'll be impacted. Now, that's not to get away from the ambition of the service, which was to grow. And what we need to do is look at how we can deliver as many of the functions as we can through a different model. And in terms of the scale of the number of patients likely to be affected, I assured the medical director of NHS Teesside yesterday of the minimal impact that this will have, given the numbers that we're currently seeing. And I think lastly, I think we all agree that I don't think there's anyone at this table that wants to see us cutting or potentially reducing expenditure on services where we see benefit. But this is the situation we're forced into, and we need to try and work as hard as we can to deliver the functionality in a different way, and maintaining good quality care.
Okay, thank you. Have we got any more? Oh, Serene, you want to come back in?
Colleagues, what's been said in the last few minutes was information known to us when we looked at the pilot scheme in the first place. There are very few services that we provide across the patch which does not have an effect or a negative effect or less of an improved effect in rural areas. It's not just this, it's a reality. And it's one of the areas that we want to have a longer term strategy to ensure improvement. And so remember, this is a policy we only agreed a few months ago. This is not something we've for years been doing, and suddenly we're finding it's, as it was said, the scale of it is okay in terms of our ambition. But either it was the right policy at the time, or it wasn't. And we were persuaded, and from my perspective, happy to go along with it to tempt this out. But I don't think we should be taking the blame for a decision taken after we were asked to take the decision we did by the Scottish Government. I just don't accept that. And I don't accept it, having done the initial work on it, that we've got anything in place that would give us an indication of, for example, our colleague said about funding. Well, we either, where do you get the savings from? What part? This is a piece of work that needs to be done. And this is not a criticism of any individual, don't get me wrong. But if we're going to say it's going to be done through savings, well, where? I mean, it's important that we discuss this through, and it's also important that we've got a plan in place, because we'll be back again on another piece of this service, not just the service, on another bit of our service, and having to come up with ideas. We'll keep the ambition, but we can't keep the service. That's what we're talking ourselves into here, if we're not careful. I'm sorry if I feel that members think I'm going on about this. I think it's one of those moments in the life of this committee that somebody has to think through here. Are we going down a road which, at the end of it, we're looking at other services, or do we speak up and let people know precisely what we want to do, how to do it, and to argue a corner with the Scottish Government about funding?
Thanks, Reen. I mean, I don't think in principle anybody, as Dr. Dougal said, disagrees. Although we have to be in a situation as a board charged with not only setting a strategic direction for the Health and Social Care Partnership, but also charged with managing to achieve a balanced budget, which we're legally obligated to do. That we have to be bold enough to say, we would like to do this, but at the moment, given the results that we're getting following the initial phase of the hospital at home, following the pilot and the startup phase, we're not getting the results and the efficiencies and the savings that the investment was designed to achieve, and we don't have the recurring budget to finance it. And you're making the point about getting the funding. I don't think that's something that the board is in a position to get involved in a discussion about asking for. That would be for the parent bodies, I think, the council and NHST side to manage that. That said, on the wider point about the prospects for other parts of the service, and the future of them, that is, as I indicated, and as the Chief Finance Officer indicated, that is why the Council has supplied us with the 800,000 transformation for £800,000 on the one-off basis for the transformation of the care at home service. And I think the council leader also included in his budget a further £200,000, bringing that up to £1 million for the extra 200,000 being for the Health and Social Care Partnership to look at other potential tests of change in order to make sure that we can, and let's not be in any doubt that we're not talking about huge expansions in the service provided by the Health and Social Care Partnership or the areas covered. But we are talking about making sure that we manage the budget that we are delegated by our parent bodies in the best way to achieve the greatest efficiency, and that we are going to be trying to transform those services in order that, everything else being equal, for no extra money, we're managing the increasing demand that we see as a Health and Social Care Partnership. Chief Finance Officer want to come in as well.
Thank you. It's just to reinforce some of the messages. In my introduction, I outlined what our responsibility is as a board, and if you just bear with me a second, I'll just find where that is so I'm saying it correctly. But we, as an IGB, collectively need to set the tone that financial management is core to our strategic aims and to us achieving our strategic aims, and to demonstrate that public money is used well. So therefore, we've got a financial strategy. We're looking at making sure that we're making best use of the money that we do have, that the resources that we do have are in the best place, and that we're making sure that the people that are most vulnerable are being cared for. We then are looking at an ambitious transformation programme that underpins this budget. But then we are at the prospect that we do have to look at prioritisation and reduction because of the scale of the gap. And I do need to say that we are at risk of becoming financially unsustainable as a board if we are not able to make decisions, because we cannot keep spending the way that we're spending. We do not have the recurring budget to allow us to do so. The IGB, based on its last financial report, is currently overspending by £5 million, and that has been heavily supported by reserves this year. So we can't keep doing what we're doing, and it does mean that we're in the space of having very difficult decisions. And if we're unable to make them, then we need to move into a financial recovery, and that's not a pleasant place to be, because that then means that you're having to stop expenditure in an unplanned way. So this is us taking a planned approach to try and become financially sustainable in the long term. Thank you.
Thank you. And it was maybe slightly before my time, but I think I'm correct in saying that from day one of the Health and Social Care Partnership and the Education Joint Board back in 2016, the board had never accepted the sufficiency of the budget that was delegated to it. Do we have any other comments on this report, or can I move on to the recommendations? Okay. Can we then hear the recommendations? I'll just read them out for to do this properly. Can we approve the proposed budget for 24-25 as set out in Appendix 1, and approve the expenditure pressures and the savings and funding proposals as set out in Appendix 2? And can we approve the allocation of earmarked reserves towards the 24-25 expenditure pressures and the use of general reserves to bring 24-25 into financial balance? And can we also note the 25-26 and 26-27 provisional budgets and the additional work required to bring these years into balance? And can we issue the directions as set out in Section 10 and Appendix 4 of the report? Is that agreed? Thank you. Thank you very much, colleagues. We'll now move on to item 8.2 of the agenda, which is an update from the Audit and Performance Committee, and that will be introduced, I think, for the first time by the committee's new chair, Councillor Sheila McCall. Sheila.
Thank you, Chair. Yes, I only had my first meeting on the 11th of March, and for those of you who did manage to attend, we had a complete technology failure, and we had a late start, and we all had to disperse into individual rooms, but somehow we managed to get it all together and actually hold a meeting and get through all the business of the agenda. So for those of you who did stay with us and were able to connect, I want to thank you for your patience and for your contributions to the meeting. And for those of you who were unable to stay connected, I can only apologise, and you can rest assured that the matter has been discussed at some length with our technical support teams here at the council area. Regarding the business of the committee, there was the standard agenda items. There was a finance update, key strategic or KPIs, the risks, which I'm going to talk about separately. We also had a clinical and care governance report, which was agreed with reasonable assurance. There was nothing of any real significance that I think we need to report separately here. Audit Scotland were also in attendance, and I was very pleased to see for them to reassure me that not only did they have the resource to meet the external audit plan, but they were confident they would meet the audit timetable. And I suppose they also it was also part of the justification, I think, for increasing their fees by 6%. Regarding the standard reports that come to the Audit and Performance Committee, it's been mentioned earlier on that going forward, it's anticipated that the A&P Committee will have a role in reviewing the progress of the strategic plan, the budget delivery plan. I think the BRG is probably going to continue in some form or another, so that we're not just doing once a year for all of these key items. And so therefore I'll be working with the IGB chair and the lead officers over the coming weeks to review the content and structure of the reports being brought to the Audit and Performance Committee, particularly with respect to the financial plan and budget performance, KPIs and risk, our strategic plan, and the transformation programme that has to be developed in order to deliver the financial efficiencies that we've set out in the budget today. I would hope to complete that work before our IGB meeting in June, so that we can bring back a further update to that. But other than that, there's nothing much to report from the last meeting from the Audit and Performance Committee. Thank you. Any questions?
Thank you, Councillor McCall. I think that's, given the discussion that we've been having about the budget, I think that's, but also the point that the Chief Finance Officer was making about continuing the budget review process. I think that's a useful intervention. Mr. Black, you've got a question.
Thanks for the report, and I'd been one of the people who couldn't get online, and despite all the valiant efforts that we had, myself and Beth were unaware or unable to get online. So part of that discussion, we'll not be able to determine what was in that discussion until we see the minutes of that. I think early sight of the minutes would be able to make it easier for us to comment in the future.
Can certainly speak to committee services or even separately give you an update of what went through the committee. We'll try and do that anyway, but we'll speak to committee services and see if we can get something out a little bit earlier on the key points, at least, or any decisions made during the meeting.
Clark.
The other thing we can do is we can, the meeting I think should have been recorded, so we can also circulate the recording so that people can watch it back. But yeah, we'll attempt to get the minutes circulated as soon as we can.
Thank you. Have we got any other questions on the Audit and Performance Committee update? Nope. Thank you very much. We'll move on to item 9 on the agenda. 9.1 is the update to the IGB's reserves policy. Chief Finance Officer, this meeting is mostly your show. Carry on.
Thank you. The IGB's reserves policy was written in March 2017, as it states in the report, and it is due to be updated. So it's now been reviewed and updated to reflect the revised IGB integration scheme, and us as an IGB, we're required to have our own reserves policy. So to just clarify, this is a governance document to ensure that the reserves policy is up to date, both in its terminology and its link to the integration scheme, but there are no changes being proposed to the level of reserve that the IGB should aspire to hold. Due to its importance to long-term financial sustainability and stability of both the IGB and its parent bodies, that sufficient usable funds are held in reserve to manage unanticipated pressures from year to year, and recognising the concern the board has regarding the level of reserves. The appendices that are provided to the report are both the current version and the updated version, so that you can see the comparison. But as I say, the main changes are in regards to the language used and reflecting the current organisation, because it has been a number of years since it was changed. The report also recommends a regular cycle for review of this policy, and it suggests that it be reviewed by December 2026.
Thank you. Have we got any questions or comments on the reserves policy paper?
Way ahead, November 2026. How often will we get updates, before that, to...
Thank you, Maureen. Sorry, I should just to clarify, the policy itself will be reviewed to make sure that it's still fit for purpose by December 2026. But the finance report that goes quarterly to the Audit and Performance Committee gives an update on reserves. So the reserves themselves are reported on a quarterly basis, but the policy that underpins the reserves will be updated. And if it requires updating prior to that, then we would do that.
Mr. Black.
It's on the paper that we've got, the additional paper here, the quality impact assessment. I'm presuming that the impact assessment from NHS Tayside and the council are pretty much similar, because we're doing an impact assessment on two different policies to enable us to say that we fulfilled the quality assessment. So is there any differences between the impact assessment of Perth and Kinross Council and NHS Tayside?
Well, maybe ask Jackie to come in, but just from my perspective, the reserves policy is our document, so it's an IGB reserves policy. The council will obviously, because it's also a Section 106 body and it can hold reserves, it has a reserves policy as well. NHST say because the financial setup's different, they won't have a reserves policy. But the impacts here in regards to what the reserves policy has upon us as an IGB, but also, what I was making in the introduction was the link that a reserves policy for an IGB to hold reserves, it's in the interests of the parent bodies because it means that we have reserves to meet unanticipated pressures should they arise. But Mike, maybe you're picking up something differently, Jackie, from the question.
Martin, can I just clarify, were you talking about the equalities impact assessment? Because I know that's an interest of yours. The format for completing equalities impact assessments is different for the council and NHST side, and I've recently experienced that through the mental health programme and the equalities impact assessment there. And one of the things that we've recognised is that we've been using locally the council's documentation around that. And I've spoken and taken advice from our legal services and legal advisors to the board. So if it was about decisions in relation to service change or decisions that the board is having to make, the advice would be that if it was a health service, we should be using NHST sites and EQIA, and if it was a council service, we should be using the councils in terms of the delivery of that. So I suppose it's really just a heads up in future. Depending on papers that are coming forward, we'll give you a summary of the EQIA and the outcomes from that, but it may be a different template if you're looking at the full documentation that lies behind that, and they'll be different for different decisions and different papers.
The responsible officer on the health and social care partnership, if anything went wrong, it wouldn't be them that would be liable, it would be the council or the health board. You wouldn't go to jail, that's what I'm saying.
I don't know about that.
Any more questions or comments on the reserves policy? No. Okay. Can we, in that case, approve we have considered it, can we approve the updated IGB reserves policy and note that the reserves policy will be reviewed by December 2026? Thank you very much. Item 9.2 on the agenda, update to the IGB's financial regulations Chief Finance Officer.
Thank you. Similar to the reserves policy, the financial regulations were written in March 2016 at the inception of the IGB. The financial regulations are a key component of the IGB's governance, and they set out the responsibilities of the IGB and officers in relation to the proper administration of the IGB's finances, as well as the internal and external audit arrangements in place. And this report updates the regulations that were written back in March 2016. And again, similar to the reserves policy, this reflects that we have a revised integration scheme and the current operation of the IGB, and the terminology within the document has been updated to reflect that. And it also proposes a regular cycle of review. There are two appendices provided in this, one which is the previous version and one which is the updated version. And one of my colleagues has just notified me that the track changes in the previous version aren't available, so we'll get that recirculated so members can see that. But the main changes are around terminology and language that's been used within that to make sure that it's up to date and it reflects our latest integration scheme. So again, I would just be suggesting that we have a regular review of the financial regulations to make sure that they're up to date.
Thank you, Chief Finance Officer. Do we have any questions or comments on the report regarding the financial regulations? No. Okay. Can we then approve the updated IGB financial regulations and note that they will be reviewed by March 2026? Thank you very much. That's all of the substantive business. Now for information, we have the 2024-25 work plan. Sorry. Yeah. Okay. So this is laying out the schedule of meetings. We said we would get back to you with dates for the future meetings. We have sought to align these dates with the requirements for reporting on the with the other IJBs and reporting on the mental health strategy. But Councillor McCall, you've got a comment on the work plan.
Yes, I have just in my verbal update committed to come back to the June IGB with an update on the Audit and Performance Committee, which isn't in here on the work plan. For June.
Okay, we will.
There isn't another Audit and Performance Committee before the next June IGB, but because we're going to be looking at what the structure and content of the Audit and Performance Committee might be or might change to, and I said I would come back in June with an update. So.
Okay, we will add that on to the June agenda. Any other comments on the work plan? Nope. And then 10.2 and 10.3 notes of dates for the future meetings of the IJB and for future IJB development sessions. Any comments on the dates? Mr. Black.
Hopefully it'll not be one, but if NHS Tayside set their budget in April, if there's an impact on their budget on what's happening, would we have to wait to May? I think there may be.
I think if there were any immediate impacts on our budget as a result of NHS Tayside's budget, then we bring that back to the board as a matter of urgency, but we have received assurances around that requisition.
Our budget is based on an assumption that the budget will maintain at the recurring level that 23-24 is. The reason that we've made that assumption is our pressures are not within NHS Tayside's financial plan. Our pressures are within our IGB plan for us to manage. We've been asked to manage our own pressures, so our assumption is that we wouldn't receive a reduction in funding from NHS Tayside. And we've made the assumption, based on Scottish Government advice, we've made the assumption that any pay uplift would be passed through to the IGB in full. I should have noted when we're on the budget paper that I will report back to the IGB following receipt of formal notification of NHS Tayside's budget to delegate to the IGB, and I'll put any associated recommendations to that at that time.
And I think it's maybe worth pointing out that I think it's in the integration scheme, but we are actually meant to be able to set our budget in the light of the council and NHS Tayside budget having already been set by the time we come to this meeting. It's not within our gift to dictate when NHS Tayside sets its budget, and it's doing it in April already into the start of the financial year, but it should have already happened as per the terms of the integration scheme. Have we got any other questions about the future meeting dates or development session dates? Oh, yeah, Councillor Frampton.
Sorry. There's no dates at all for the Tayside Mental Health Services strategic update or the primary care strategies. Is there anything planned?
I can just confirm that we have agreed as a board to receive the written report on the mental health services update in June and October. So if they're not in there, we'll make sure that they are. Thanks, Michelle.
And Mrs. Auld, last comment.
Thank you. Some members of the board recently attended a visit to Broxton Dental Practice, and just be nice to recognise the effort that the staff there went to host us and say how valuable that was. And I just wonder, as was mentioned at the time, that it might be useful to discuss our observations and findings and some of the information that we were party to from that visit, just at either a future development session, and also wondered if it would be useful for someone from the practice to come and present to the board.
Thanks, Mrs. Auld. That's a useful prompt, and I think it would be certainly very useful to have a discussion about that probably little known or little understood service, but one which I think all of us who visited were extremely impressed by, and which I think gets very good ratings in the, for example, the care opinion surveys. I think it'd be great if we could have a discussion about that, and we'll schedule that on for one of our development sessions.
Okay,
thanks for that useful suggestion. Thank you. Okay, if there's no other items of business, Mrs. Summers, go on.
Just something that was in the press recently. There's been a proposal to cut the bus service between PRI and Nine Wells, and you confirm whether that was a decision by the bus company, or can Perth and Kinross Council influence a decision to reverse that, because it's very well used, by both by patients and the workforce,
Yeah, it's a very relevant question for, as you say, both patients and workforce, and residents of Perth and Kinross. It was a decision by the bus company. The chief executive of the council has spoken to Stagecoach, and certainly some of the proposed changes have been at least delayed. My understanding is that those discussions are ongoing. I mean, I have more of an insight, but I'm not sure whether it's confidential at this point or not. So just to reassure people that the importance of that service connecting PRI and Nine Wells is recognised, and there are ongoing discussions. Chief Officer, then Mrs. Hamilton, then Councillor McCall.
And just to say, the interim chief executive of NHS Teesside has also written to Stagecoach, and I've seen the letter, and there are ongoing discussions and hopefully involvement of people who use the service frequently in terms of any ongoing changes that might be made. So we'll keep you posted, Maureen.
And that was going to be Mrs. Hamilton's point. So Councillor McCall.
Just also going to reassure you that as a user of that particular service to get to and from NHS Teesside board meetings, I have a very vested interest in making sure that it continues in one way, shape or form. So I'm all over it. I don't know if I'll be very successful, but I'm keeping a close eye on it. And I think it's also fair to say, Colin, that the leader of the council as well as the chief exec, and I think across the whole of the council cohort is supportive of the work that's been done on this.
Thank you very much. Thank you, members, for your engagement and attendance today. Thanks to all of the officers who brought reports, but particularly because this was our budget meeting, to the Chief Finance Officer, but also the finance team sitting behind you, and all of the service managers and staff that have supported the budget process. I think it's obviously a huge amount of work, and I think we just want to recognise that. There being no other business, meeting stands adjourned. Thank you.